Hi, my name is Wen. I'm a PhD student at the University of St. Andrews. I'm going to talk about our study on efficient identification of patients eligible for clinical studies using case-based reasoning on the Scottish Health Research Register SHARE. As we all know, participant recruitment is the first and is also a crucial step to a successful study, but the process can be time-consuming and labor-intensive. Thus, much effort has been seen in developing EHR-based research support service, which can utilize consented registrants' electronic health records to help clinical studies to find eligible participants more efficiently. SHARE is one of them. SHARE has more than 280,000 registrants now, and it covers 6.4% of the over 16-year-old population in Scotland. SHARE's recruitment procedure is first to identify potential participants through searching their electronic health records against certain clinical codes agreed by researchers, and then contact these people, pass on the information of those who are willing to participate to researchers. If they can pass further screening, they will be recruited in the study. Analysis of 24 completed SHARE projects show that the majority of them were recruiting only the residents in Eastern Scotland. The overall target fulfill rate was 34%. 29% of the candidates provided to researchers will be recruited. The number of recruited took up only 5% of the number of people identified at first. The number of potential candidates ranged from 94 to 509 per study. On average, 237 candidates need to be screened either by SHARE staff or researchers themselves. This is not a small workload. So we were thinking, can we use a data-driven method to find eligible participants? Will we find the same participant as traditional way of searching electronic health records? Thus, we designed a study to retrospectively assess the predictive performance of case-based learning method in identifying study participants for completed projects in SHARE. Project selection criteria was the recruitment project should have ended before the end of 2017. It was recruiting across the health boards in Eastern Scotland. Finally, 9 projects were included in this study, and they involved 119 participants in total, with each project ranging between 2 to 28. We adapted the case-based learning method from Mioto and Wen's study. For further details, please refer to their study. But basically, it locates most frequently shared clinical features between participants already recruited in a study, finds their central tendencies, and uses them as an imaginary target patient. Then everyone will be compared to this target patient to get a relevant score. The higher the score is, the more likely a person is believed to be recruited into the same study. In our study, our subjects include 190 confirmed participants. Individuals are identified at first but not enrolled, and 30,000 randomly selected from the SHARE registrants from Eastern Scotland. Each subject was flagged as identified or not, recruited or not, according to SHARE records for each study. We extracted diagnosis, procedure, prescription, and laboratory test results for these people. We apply a time window to those longitudinal clinical data from 2010 to 2017. Each project was analyzed separately by twofold cross-validation. Half of the 119 participants were used to train a predictive model, and the other half were combined with the remaining subjects as unseen validation set. We determined shared features as those of which the frequency among participants exceeds a threshold of 80%. We created the target profile using the average occurrences of those features. The relevance score was a cosine similarity calculated between each subject and the target profile. ROCOC was calculated for either testing fold respectively, and average scores were obtained for projects individually and for the 9 projects as a whole. The confidence interval for ROCOC was generated through 2,000 bootstrap replicates. A ranking list was generated for each test set, with individual relevance score decreasing for assessment of its ability to locate the person recruited, using metrics such as precision at top 5, precision at top 10, mean average precision, and mean reciprocal rank. The best possible result for the list, with confirmed participants ranked at the top, and the worst result, a random list, were also obtained as references. The metrics were averaged across all 18 ranking lists respectively. We also calculated the proportion of the persons identified by searching electronic health records in the traditional way in the top 50 individuals found by the ranking list. The ROCOG for each project and each fold are shown in Table 1. The mean ROCOG for relevance score was 0.815 over 9 projects. One project had an unacceptably low ROCOG of 0.337, worse than a random guess. Another project gave poor performance. Its ROCOG was 0.619. The remaining 7 projects were either good or excellent. Ranking list results are shown in Table 2. Overall, the ranking list failed to present the participants at either the top 5 position or the top 10. Performance improved when trying to find participants from the top of the list of roughly 30,000 subjects compared to a random list, but was still far from optimal. The proportion of those identified by traditional way in the top 50 of the ranking list for each project are presented in Table 3. On average, 21% of the persons ranked within the top 50 positions on the ranking list were the same as found by the traditional method. Our ROCOG results indicate that we can reliably and retrospectively predict the recruitment status for unseen person in 7 of the 9 projects. ROCOG is either good, that is above 80%, or excellent, above 90%, providing strong support for our intention to use data-driven method to identify participants from electronic health records. 2 studies were harder to predict. We speculated that for import study, the poor result was caused by only 2 participants being recruited, so only 1 person was used to derive the target. For the other study, the relatively loose inclusion-exclusion criteria might result in an inherent inability of capturing a representative target due to scattered participant characteristics. Evaluation of the resultant ranking list showed poor performance in retrieving the participants at the top. The ranking performance was the worst for import project, consistent with the ROCOG result. The assessment of the consistency of patients identified by case-based reasoning and traditional way shows significant discrepancy. However, it is unknown whether the most likely participants identified from our ranking list will have been recruited or not due to the retrospective nature of our study. So there is an inherent lack of discriminative ability involved. This is also one of our limitations. Our study has the following strength. We have made evaluation on recruitment results of real clinical studies. The clinical data we extracted involve multiple health boards and multiple data sources. They are population-based and hence are not flawed by selection bias. We have used an analog of an existing proven methodology augmented with cross-validation and relative ranking analysis. Apart from the aforementioned limitation from the retrospective nature of our study, we acknowledge that the final recruitment status is not a perfect outcome measure because it is affected by some external factors rather than clinical information alone, such as personal preferences. The algorithm might have correctly identified an eligible participant, but this person had not been enrolled in the study due to personal reasons, although our evaluation result will only be underestimated in this case. However, the clinical data used for this study do not consist of free text clinical notes, possibly would impact on our performance. In this study, we have demonstrated that case-based reasoning performed well in predicting recruitment for population-based clinical studies using Scottish electronic health record data. It might be worse for future study to also introduce measures with regards to ranking lists in addition to ROCOG measure to make a more comprehensive evaluation. The provision of more abundant clinical data, including narrative clinical notes, might be able to improve the predictive ability. Planned prospective studies comparing the actual recruitment results for persons identified by different methods should help address the question of which ones are most suitable for finding potential participants. Thank you for watching my presentation.